Yes, we are a little bit behind, but so it gives me great pleasure to welcome up to the stage Professor Olivier Joannes-Boyau. So he is the Chief Physician of a large intensive care unit in Bordeaux, and he's also the Chair of the ICU Committee of the French Society for Anesthesiology and Intensive Care, and many other distinguished positions. And also Professor Giacomo Grasselli, who's as a physician as Assistant Professor of Anesthesiology at the University of Milan, Head of an Intensive Care Unit at the Grand Hospital Maggiore Policlinico, but most importantly is recently elected General Secretary of the European Society of Intensive Care Medicine and is elected President of the Italian Society of Intensive Care. So great to have you both with us. So I'll turn to my co-chair at the moment. I think we're going to spark off a little bit of debate just in 10 minutes or so.
Thank you. Welcome, dear Olivier Jambou and Giacomo Grasselli. And in this session, there are very interesting topics that could you show your opinions about this, especially about the pharmacokinetics and the wasoplegy in septic shock patients, and also to use hemoadsorption system.
Yes. Well, I think that in this session we've heard many important messages. The first is that we know that sepsis is a dysregulated immune response. The organ failure in sepsis is due to dysregulated immune response, and what I've learned is that removing inflammatory mediators can in some way not only remove the pro-inflammatory molecules, but also in some way give a sort of immunomodulation, so to restore the regulation of the immune response, which is, I think, very, very interesting and gives an important insight on the potential of hemoadsorption, the use of hemoadsorption in septic patients. Although we still need to understand better in which patients this is useful, because there are certainly subsets of patients that can benefit more, which are the endpoints that we have to consider for the future studies. And also, I think that it was very important what Antoine showed, especially in sepsis. The issue of clearance of antibiotics is crucial. So we need to understand better how much of the antibiotic is removed and how much we should increase their dosage in septic patients who undergo renal replacement therapy, ECMO, and every type of extracorporeal support, and maybe also to change our dosing of antibiotics, not only on the dose, but also of the schedule of administration during those therapies.
Yes, it was a very interesting session, and we have very encouraging preliminary results for septic patients, but for all the patients with disruption in inflammatory response. As usual, we have more questions than answers for the moment, but it's usual in medicine for new techniques and new therapeutics. But we have seen that we have very interesting results for a large panel of patients with inflammatory disruption, burn patients, septic patients, and also patients with liver failure that have also inflammation disruption. The problem is in the future to select very carefully the patients and to know exactly which membrane, which sorbents we have to use with the specific patient to be able to remove exactly the molecules that we want to remove and to restore the homeostasis and the regulation in the inflammatory response. And in the other end, we have also to manage carefully the drugs, because if we remove or restore the homeostasis, but we remove the antibiotics or other drugs that are mandatory for the patient, we will have conflictual results in our studies. And it's, as said Professor Antoine Schneider, it's really important also to monitor the drugs, antibiotics and others, when we treat our patients in the future. And it's really important to exactly understand which patient we want to treat with hemoadsorption, know what we want to remove, and focus on this. And the important point that was clearly addressed by Professor Cole from England is the primary and secondary endpoints that we want. The 28 days mortality is probably not the first endpoint for the moment. We have more focus on other endpoints at very short primer mortality and other endpoint to know exactly if we have important benefit with hemoadsorption before to know if we can reduce the mortality at 28 days, because it's a difficult point to achieve.
So I might follow up on this point, because I think it came out in many of the talks. It's quite difficult to do good quality studies in this setting. We probably have to start off with doing relatively small studies in order to achieve proof of concept, safety and efficacy. But what endpoints should we choose for these initial ones? Should we be looking at physiological type endpoints, or should we be looking at mechanistic type endpoints like removal of a target mediator, which actually might be difficult to pin down? Any thoughts on that?
Well, I think that we certainly need physiological studies, so studies with the physiological endpoint, which is probably also more relevant also for the clinical, as a proxy of a clinical endpoint rather than the removal of a specific molecule. You have seen studies on, for example, with Cytosorb cartridge that didn't even show any difference in IL-6 levels pre and post treatment, and this is probably related to the baseline condition, to the baseline selection of the patients. And while, for example, in septic patients, the dosage of vasoactive drugs, the duration of mechanical ventilation in patients with ARDS, I mean, other endpoints that are clinically relevant but not as hard as mortality, because especially in critically ill patients, mortality is affected by many things, and it's difficult to discriminate the effect of a single intervention on such a complex outcome like mortality.
Yeah, I think we need all the type of the studies. Physiological studies, it's important to specifically select the patient for future bigger studies, and clinical studies are important to know exactly the benefits that we can give to our patient, and also some safety studies with the removal of good drugs. And we need all these studies to build in the future bigger studies with all the elements to build the best studies as possible.
As you said, that the best way for pharmacokinetics and drug treatment is monitor, as Professor Schneider said, but it's not, it's best, but it's not easy, it's not practical. I want to learn that in your practical experience, how do you manage your drug treatment during hemoadsorption? Do you give interruption to treatment during this procedure, or do you increase the doses?
It's a very difficult question, and we could discuss about this during 2 hours. We start to have good information about the removal by the renal replacement therapy, usual renal replacement therapy, but it's remained difficult to manage drug removal during renal replacement therapy. And it's more difficult to manage it for hemoadsorption, because we will use the hemoadsorption only for a short period, 3 or 6 hours, sometimes 8 hours. And it's very difficult to monitor the drugs and to have the answer of the monitoring, the dose of the drug in the patient in a very short period, because we have to use the spectrography and other difficult technique to have the results rapidly, and it's difficult. I think the best for hemoadsorption is probably to give the drugs just after the session to be sure that you have the drug at the good dose as long as possible to the patient. And you know that during the hemoadsorption period, you have probably a removal of the drug. But if it's just at the end of the 24 hours, you have the drug during 18 hours, and after perhaps we will remove the cue of the drug for 6 hours, but not so important.
I think I've been told we should wrap up now, but thank you very much, everybody.